to include the coronary arteries, but also the major arteries and the major venous kind of diseases that you may encounter with your patients. So, but to kind of start the discussion about the vascular systems, we really have to focus first on talking about hypertension and how it impacts that vascular system, because it's kind of the setup for a lot of the different diseases that we're going to encounter. So the first lecture is going to be just kind of a overview of hypertension and then a discussion of essential hypertension. The second lecture is going to be a discussion about secondary hypertension and hypertensive crises. And then the third lecture is atherosclerosis, lipid disorders, and then we move into ischemic heart disease, acute coronary syndromes, and then arterial disease and venous diseases. So that's how we will go through our lectures for this block. But I wanted to start this with a case study, and it goes like this. So you have a 50-year-old female who has a long-standing history of hypertension that presents to your clinic for follow-up for elevated blood pressure. On review of medical history, she has had hypertension for the past 20 years. She insists being compliant on her medications, but she's currently on 3 meds, and she's also taking large doses of potassium supplements in addition to increasing dietary intake of potassium for persistent hypokalemia. Her blood pressure in clinic today is 210/130. She denies any symptoms, headaches, visual changes, or chest pain. Patient is directed to go to the ER, the local ER, which is about a 40-minute drive away, immediately for evaluation, admission, and treatment. She's driven to the ER by her teenage daughter, who just has a learner's permit. And by the way, it is upstate New York, around the Buffalo area, and there's a snowstorm going on. She was subsequently admitted to the ICU for a hypertensive emergency and was given IV antihypertensives. Despite recent increases in dosing of potassium, potassium is still low at 2.9, normal being 4 to 5. So kind of setting the stage for this lecture and next lecture. When we talk about hypertension, we almost kind of talk about it flippantly because it is so common out there, and we always it's white coat hypertension, just very dismissive about it. But this is actually a very major cause of morbidity and mortality in the United States. When we look at the CDC fast facts on hypertension, in the United States alone, about half of American adults have hypertension when you use the criteria of a systolic greater than 130. About 1 in 4 adults with hypertension have their hypertension under control. So 3 out of 4 hypertensives do not meet goal for their blood pressure regulation or blood pressure control. About half of these adults with uncontrolled hypertension have blood pressures that are still exceedingly high, greater than 140/90. So these are folks who either should be on medications or are taking medications, and yet their blood pressure still remains above that 140/90 threshold. About 34 million adults who are recommended to take medication may need to still have it prescribed or to start taking it. So either they're not getting the care that they need because they don't necessarily have the means to take it, or they're dismissive about it. Because with most hypertensives, they don't necessarily have symptoms of their hypertension, right? When you go to get diagnosed with strep throat, there's a symptom that brings you in to get that treatment, right? You're going to want to get that treatment because your throat feels like you're swallowing glass every time you swallow, right? You want that antibiotic to treat it. Hypertension, you don't have that reinforcement, that positive reinforcement. I'm not going to take this pill to feel better because I feel fine as it is, and in most cases, actually taking that pill might make you actually feel worse. So there's no motivation. Initiation guidelines, that's what I'm going to teach you, because that's what the PANCE will kind of test you on. But you can see, though, there is variation. I remember when JNC 7 came out, it kind of changed our definition of hypertension, and there is even pockets within the family medicine community that still uses the JNC 7, JNC 8 thresholds for treatments and stuff like that, as well as our goals for treating too. But one key thing to note is that to be able to diagnose with somebody with hypertension, it's not one abnormal pressure. You have to have at least 2 abnormal pressures taken at different times in order to diagnose somebody with hypertension. You've worked in the military treatment facilities, we always have folks come back for their 5-day blood pressure check, right? This is part of that because we want to verify that that's not an isolated elevation, that this is something that is chronic and persistent. So a couple of definitions before we really jump in. So you may have heard the term primary, which is also known as essential hypertension. This is a form of hypertension, and oh, by the way, it's the most common form, where there isn't another condition causing it. So in essential hypertension, think of the blood pressure elevation as the pathology, not a symptom of something. Okay? Is this a fever because it's a fever, or is this a fever because there's an infection going on, kind of thing? So kind of think of it like that. So essential is there's not another process going on causing that blood pressure elevation. Secondary hypertension, on the other hand, has another pathology that is present, and one of the symptoms of that pathology is blood pressure elevation. Okay, we're going to talk about those tomorrow. Hopefully, then that will make a little bit more sense when we say that the blood pressure elevation is a symptom of that disease. Other things you may have heard is white coat hypertension. This is probably the most common thing you're going to hear in clinic when you approach a patient who has an elevated blood pressure. It's, oh, I just have white coat hypertension. So what does that really, truly mean? It basically means the blood pressure is only elevated when they're in the medical office. Kind of think of this as like an anxiety kind of thing. They're anxious to see you because what do they associate you with? Shots, confronting them about things they need to change in their life, right? They know they're doing stuff bad, let's change that. You know, they smoke, okay, well, you gotta stop smoking. You're kind of calling them out on it, right? So they associate you with bad things and they get anxious. But when they go home, their blood pressure is normal. So if I were to start that person on blood pressure medications who have normal blood pressures at home and only have abnormal in that 1 hour that I see them once a quarter, imagine what's going to happen to their blood pressure if you put them on that antihypertensive. You're going to drop it, and now they may be passing out or having syncopal, pre-syncopal or actual syncopal episode because their blood pressure is too low. They have hypotension. So it's a tricky thing to treat and manage if they do, in fact, have white coat hypertension. The next term is masked hypertension, and this is somebody who, when they come to see you in the clinic, their blood pressure is actually normal. You almost have a calming effect to them for some reason. So their blood pressure is normal. You don't want to act on it because everything looks great. But when they leave you, they go back to the stressors of their home life or whatever, their job, and now their blood pressures are through the roof or they're elevated. Imagine how difficult that is because most of the time, blood pressure elevations are asymptomatic until it's too late, right? So if I'm not identifying this patient as having hypertension in my office, their initial symptom or the initial presentation of this blood pressure is a complication has developed. So a difficult form of blood pressure to manage. And then the last term I want to talk about is a resistant hypertension, where despite being on medications and being on appropriate medications, appropriate dosages and stuff, and they are compliant, meaning they are taking their medications as they should be taken, they still have elevated blood pressures. And resistant hypertension should probably make you think that something else is going on, and blood pressure is not the only thing that needs to be addressed in these patients. So to diagnose a patient with hypertension, we said we need at least 2 to 3 data points, right? But depending on the guidelines that you use will help you determine what your thresholds are to be able to diagnose somebody with hypertension. So ACC-AHA, they say systolics, persistent systolics greater than 130 or diastolics greater than 80 technically meets the definition of high blood pressure or hypertension. When we try to come up with how we diagnose this, in office measurements are routinely falsely positive. So there are more accurate ways that we can do it. So ambulatory blood pressure monitoring is the most accurate way, but we're going to talk about some of the limitations of doing that. But even home measurements are better than in-office ones because this person is now in their environment, their normal environment, the normal stressors and everything. What is their blood pressure doing in that environment where they are potentially there for what, 16 hours a day, opposite the 8 hours that they're working? What is their blood pressure in that environment? So when we talk about in-office inaccuracies, things that may cause a falsely elevated blood pressure, there's a number of things that we should be thinking of and looking for. And this is important for you when you teach your medics, your techs, your foremen, your nurses to take blood pressure. Make sure they are eliminating a lot of these things that could cause that false elevation. So something as simple as the patient has a full bladder and just needs to go to the bathroom can cause an elevation of 10 millimeters of mercury in both your systolic and your diastolic. So simply just having a full bladder could put somebody over the threshold of having an elevated blood pressure. So make sure they have an empty bladder. What's another thing that we tend to do in the medical clinic? Well, usually we are running behind, right? The patient's been sitting there for 15 minutes, we're running behind. So your medic, your tech, your foreman, go grab the patient, bring them back hurriedly. They're sprinting after you. Sit them down, pop the blood pressure cuff on. Is that adequate? No, because they're probably a little anxious because they're kind of getting hyped up for that energy you're giving to them, right? So what you need to do is give them the opportunity to kind of sit for 5 minutes. So maybe instead of immediately taking the vitals, have your medic, your tech, your foreman, your nurse talk to the patient first, kind of see what's going on, let them relax a little bit, and then take the blood pressure. And then you have to also look at medications. Are they taking medications for their blood pressure and they're not taking it? Or are they on other medications like your Adderalls, your stimulant kind of medications that can cause that elevation in blood pressure and have that side effect? So when you encounter a patient, you take their blood pressure, the initial one is elevated. What you need to do, instead of immediately jumping in and recording that in the medical record, you need to repeat it. But give them at least 5 additional minutes to kind of just sit there and relax before you take your blood pressure. And this could be something that you and your tech talk about, where you as the provider will take that and repeat that blood pressure after you've had a chance to talk to them as part of like a physical exam, right? We teach you in clin skills to take your own blood pressure, right? So that is a skill that you can and should use in your clinical practice. But if you give them that time and you still see this persistent elevation in their blood pressure, you're going to want to bring them back at a later date and repeat that blood pressure. But this time, make sure they don't exercise prior to coming in. Make sure they don't smoke prior to coming in, at least 30 minutes, it says. And don't have them drink any caffeine, because all of those things could cause that false elevation in their blood pressure. And you don't want to be treating a false value. Another thing you can do, if you have this available to you in your clinic, is to actually do an ambulatory blood pressure monitoring check, which you can see in this picture here. It's kind of this blood pressure cuff that gets attached to the patient, and then it attaches to a satchel where your blood pressure monitor goes. And they wear this for 24 hours and just kind of walk around, and every 15 minutes or so while they're awake, It's going to take their blood pressure, and it's going to record a data point. And then they wear this when they're sleeping as well, and every like hour, it takes your blood pressure while sleeping and then records it as a data point. And then they bring it back to you the following morning, and you download the data, and it will give you an idea of what their blood pressure is doing over the course of the day. So if somebody's saying, oh, I just have white coat hypertension, and they bring in this, and you find out 80% of the day they have a blood pressure that's too high, then you can call BS on this being white coat hypertension and actually say, this is hypertension. So, but there is some limitations to this. Yeah.
Do you have some cardiology?
It depends. It depends on capabilities. Most primary care clinics do not have this ability. When I was the department head for operational medicine, Naval Air Station Oceana, I did have this because I invested my funds into buying this. They're about, I think these machines are about $3,000 to $4,000 a piece. This was 10 plus years ago. So you're giving them this $3,000 machine. You hope they don't break it, and you hope they bring it back. So there are limitations. At Belvoir, we did not have these monitors. We actually had to send them to cardiology. So it kind of depends. Sometimes it may be an internal medicine clinic that you'll send them to get this done, but it really just depends on your MTF and MTF. But, so those are a couple of limitations to doing ambulatory blood pressure monitoring, even though, think of this as the gold standard for diagnosing hypertension. I would be remiss if I didn't talk about preventative services. So the USPSTF does have recommendations for screening. So in your clin core groups, if you are struggling to come up with your preventative service things, throw this in there. The USPSTF says adults ages 18 to 39 should have at least one blood pressure check every 3 to 5 years, if it's normal and they're low risk. Now, if they've had abnormal or they are higher risk, then they do recommend annual. But once you get to 40, now it's recommended to have an annual screening for blood pressure. So that is your USPSTF recommendations for blood pressure. So you've taken 2 to 3 blood pressures on separate occasions, and the blood pressures are elevated. You now have diagnosed this patient with hypertension. What other things should you do in addition to the history and your physical exam? Well, you're going to want to get some ancillary studies, and the recommendations is actually to do this battery of tests. I know last block we were talking about don't shotgun stuff. This is not a shotgun because there's a reason we get these labs. And it could be that we're looking for other things that could cause this. So at CBC, we're looking for both polycythemia vera, so an elevated red count, that can cause an elevated blood pressure. Even anemia, especially severe anemia that triggers a compensatory reaction, can cause an elevated blood pressure. So check your blood counts. Look at the calcium. Hypercalcemia can cause an elevation in your blood pressure. Look at your TSH. We're going to talk about this tomorrow, but even high-end, so hyperthyroidism can cause it, but even hypothyroidism can cause blood pressure elevations. And then the other labs are really looking at helping us identify risk factors, because that's going to help us when we start talking about management. What is our goal? So when we do things like looking at your fasting glucose or your A1C, looking at your lipids, that will help us be able to calculate what their 10-year risk is of cardiac disease. And then looking at your UA microalbumin to creatinine ratio, and then looking at your BNP, we're basically looking for secondary complications related to blood pressure. So maybe this is not something that's only been going on for 2 months. Maybe this is something that's been going on for 20 years, and they actually have kidney damage because of that blood pressure elevation. So So that's the reason we do this particular workup in this patient. And this is not a shotgun kind of approach. Now, some additional studies that you may want to add to your workup kind of depend on what you're seeing with your patient. So you may want to get a chest X-ray if you're suspecting somebody has coarctation of the aorta, right? We talked about that last block, the rib notching from that. So you have like a pediatric patient who's coming in with an elevated blood pressure. Maybe that's the person you should be doing a chest X-ray to look for rib notching and coarctation. Maybe they have evidence of left ventricular hypertrophy on their EKG. Maybe we should get an echo. There's a ClinCore case that is exactly this. Maybe you should get an echo for that patient. So a couple of things, there's a couple of additional studies that you can order when you diagnose somebody with new hypertension. Other things you want to look at is look at for additional risk factors that may prompt you to want to address their overall health. So smoking history, let's talk about smoking cessation. Let's talk about weight issues and those kinds of things. But when we talk about essential hypertension, because there isn't a specific disease that's identified that's causing this blood pressure elevation, the way we treat this and manage this is, one, let's prevent it by managing our risk factors, and then let's recognize it early before complications start to develop because of this disease. So let's make sure we address the unhealthy lifestyle habits of our patients before they develop hypertension. So let's live a healthy lifestyle. So when we have essential or primary hypertension, there are so many different things that can contribute to this elevated blood pressure, and so many different organ systems that have a play in this. But really kind of think of the most important organ that is maybe contributing and causing this is the kidney. Okay? The kidney modifies and regulates that blood pressure in a couple of different ways. And really it kind of comes down to is kind of a self-preservation. The kidney senses if it's getting enough blood flow to it, and if it's not, it assumes it's because the blood pressure is too low. So it's going to trigger the mechanisms to raise your blood pressure. And that could be inappropriate because every other organ system is getting the blood supply that it needs. And so the kidney is sacrificing those other organs to preserve itself. There's other things, so ion channels could be inappropriately functioning, so like your sodium ATPase pumps may not be working right in the kidney, and then there also may be problems with the hormonal regulation of the renin, angiotensin, aldosterone axis. So a couple of different ways that the kidney can affect your blood pressure. Now, ultimately, how do you calculate your blood pressure? It's your cardiac output multiplied by your total peripheral vascular resistance. Okay, so you can see on this flow chart the two things that ultimately lead to your blood pressure. And when you're looking at all the different factors that go into regulating your blood pressure, you can see that it's not just one thing particularly that fails that leads to it. It is a very tightly regulated system. But you can also see in red are things that raise your blood pressure, and green is things that lower your blood pressure. And looking at that chart, what do you think the body thinks is more important? Raising, right? What's going to kill you 2 seconds from now? Is it a 160 over 100 blood pressure, or is it a 40 over 30 blood pressure? It's that low, it's that hypertension. So you can see our mechanisms in play here are actually really focused on raising that blood pressure. There's very few green spots if we exclude the local regulators section on that. There's very few things that are green that lower your blood pressure. So your body is really focused on keeping that blood pressure to meet that perfusion pressure necessary to keep those organs working appropriately. Please don't memorize everything under each of these things. Just know that this is a tightly regulated, complex system with multiple factors kind of regulating your overall blood pressure. Going back to the kidney, you can see at the very bottom kind of here, your kidney has a huge thing for regulating the blood volume. And you can see it's got 3 factors that go into raising your blood pressure. But one of the things it does have to help you lower blood pressure is this pressure natriuresis, where if the kidney perceives that that pressure is too high, it's going to start dumping sodium, which is then going to pull water along with it, and so you start to lose volume because you're getting rid of that sodium and getting rid of that water, and it in hopes that it's going to lower that pressure. But imagine what the consequences of this is going to be if that pressure doesn't respond appropriately, because one of these other things is going on that's causing that higher. So you're dumping lots and lots and lots and lots of sodium. What's that going to do to your electrolyte balance? So this could be something that has some additional consequences because the kidney thinks it's trying to do what's appropriate. When we look at the peripheral vascular resistance side of the equation, you can see, yeah, there's a lot of red here, but you can see there's actually probably just as many greens, especially when we factor in the local regulators. So the immediate artery or the immediate vein is going to recognize that the pressure is too high in that area, and so it's going to release factors that are going to have that immediate kind of direct impact there. So, so local regulators are important for lowering the blood pressure. So now that we've discussed the diagnosis of essential hypertension, how do we manage it? Well, first of all, you got to know what your goal is, right? Because when we look at the different societies, the definition and the goals are going to be very, very different depending on your patient. So in JNC8, which came out in 2014, patients 60 years or older, they say, keep the blood pressure less than 150/90. That's your goal, right? But if it's patients are younger than 60, then 140/90, and that's really kind of the goal for JNC8 is just 140/90. But we said we were going to focus in on the ACC/AHA guidelines, and you can see when we look at this, one of the key things, so it says, okay, known cardiovascular disease. So this is somebody who has had a heart attack or has peripheral vascular disease. We're going to be more aggressive at managing that. But one of the things you notice is it says, what is their 10-year ASCVD risk? And that's going to influence what your recommendation is. Because if you have somebody who has an ASCVD, so atherosclerotic cardiovascular disease event risk, that is 10% or higher, then is recommended you get them less than 130/80. If they have a 10-year ASCVD risk that's less than 10%, and they don't have any additional risk markers or anything like that, then it's reasonable to have them less than 130/80. So it's not a recommended, it's just, hey, yeah, maybe you could. But if you already are on one medication and you're like 132/81, do you need to add that second medication? And the answer is no, because you still meet that goal in that patient who is overall low risk. Okay. Same goes for, they're not on any medications, but they have a low risk and their blood pressure is like 130s in the 80s. Do you need to start them on a medication? The answer is no, not necessarily. You can talk to your patient and see if they are willing to put up with potential side effects in order to get a tighter control of their blood pressure. But it's reasonable to not do that. So knowing your patient's risk factors and their risk is important. But when we talk about treatment, we tend to focus on the medication side of things, right? That's why our patients come to us, because they want a magic pill that we can give them that will take care of all of their concerns, right? They don't want to necessarily have to put in that effort. In hypertension management, there is clear evidence that lifestyle changes can actually have even more of a profound impact on lowering your blood pressure than even medications can. So even if you do prescribe medications for a patient, it is important for them to make lifestyle changes to lower their blood pressure as well. What this can mean is, one, better control of their blood pressure by doing these lifestyle changes. Two, maybe we only need one agent instead of adding a second agent. Or three, maybe we don't need to really treat this at all. Maybe we don't even need medications if they were to abide by these lifestyle changes. And when we talk about lifestyle changes, the one that has been shown in literature to actually have the most profound impact is actually the DASH diet. On average, somebody who strictly adheres to the DASH diet can have a drop of 11 millimeters of mercury in their blood pressure. So you're talking about somebody who is 140 systolic could drop down to 129 simply by changing their diet. But let's look at some of the additional risk factors that your patient may have. Maybe they're obese. Well, if I lose weight, I can expect at least a 1 millimeter mercury drop for every kilogram I drop in weight. So in evidence, or in the literature, it shows on average 5 millimeters drop simply by losing weight. If I reduce sodium, that's another 5 or 6 point drop. If I start exercising, I get off the couch and I start exercising, you can see I can have additional drops in my blood pressure. And these work together. It's not you only get to pick one and then that's all you're going to get. You can add these two things. So doing the DASH diet, which can lose weight, and then you start exercising, you can have a profound impact on lowering blood pressure. Smoking cessation. So this is important because of that nicotine reaction, you will have a transitory elevation in your blood pressure, which may not cause any problems if they only smoke 1 cigarette a day. How many smokers do you know that only smoke 1 cigarette a day? Probably every 2 hours, 3 hours, 4 hours are going and smoking, right? So you get that transitory increase in your blood pressure, and then it finally starts to get out of your system, it starts to drop, and then they're smoking another cigarette, and then it goes back up. Active duty, we see an uptick in smoking on deployments. And the reason for this is, smoking is like the only good excuse to get up from your work center and go take a break, right? So people use smoking as an avenue to take a break during the day, because we don't really legitimately endorse taking breaks during your watch or whatever, right? So people pick up smoking while they're deployed because they want to have that 10-minute break. I've seen commands successfully reduce their smoking uptick during deployments by allowing bubblegum breaks instead. So it gives them 10 minutes just to get away from their work center, their watch, whatever, to just take a breather before they come back. They've shown significant decline in people smoking. So something to think about when you get out to the units. Other things, relaxation, yoga, those kinds of things. You may be wondering, well, this is just voodoo, right? Well, no, it's not. Because when you have somebody who has anxiety and such crippling anxiety that's causing their blood pressures to be so far elevated, by me taking a moment of meditation or whatever, a break, I can reverse that sympathetic nervous system overdrive, and that will lower your blood pressure. So taking those moments to kind of do mindfulness exercises, relaxation techniques, those kinds of things can impact your blood pressure and lower it by addressing that sympathetic nervous system overdrive. Caffeine reduction. Caffeine intake doesn't really cause a chronic elevation, but it does cause transitory elevations. And the reason it doesn't cause chronic elevations like we see with our patients who smoke is usually you drink your coffee for the first 2 hours or so of the day, right? You don't necessarily have coffee, the average person doesn't have coffee in the afternoon, right? So maybe only 2 or 3 hours are they actually dealing with the implications of that caffeine intake. But cutting back can lower your blood pressure. Now, DASH diet is actually a acronym for something. It means dietary approach to stop hypertension. This again, literature has shown as one of the best at lowering your blood pressure with lifestyle modifications. And when you look at what the DASH diet encourages, these are the things that we've been discussing when we talk about food pyramids ever since we were kids, right? Got to eat more fruits and vegetables. Let's eat healthy grains. Let's eat lean protein. Let's cut out fried foods and those types of things. When we talk about specific dietary trends in cardiovascular health, the one diet that has been consistent to show improvement is the Mediterranean diet. And the Mediterranean diet is basically your DASH diet, right? It's a lot of lean proteins, it's a lot of fruits, it's a lot of vegetables, and a lot of whole grains. So, DASH diet recommended for all of your patients for hypertension, and the Mediterranean diet overall for overall cardiovascular health. So, we talked about the lifestyle modifications. Some patients, lifestyle modifications may not be adequate. Maybe they're going to need that medication to actually lower their blood pressure. And I know you've talked about these in pharmacology, but there's a couple of overarching drug classes that we can use to lower blood pressure. This should not be new to you, but you have your diuretics, your sympatholytics, your vasodilators, and your RAS antagonists. And there's multiple medications involved in each of these classes, and we'll talk about what our primary ones are and what maybe are adjunctive ones that we can prescribe to our patients. So when we look at that chart that shows you how we get blood pressure, you can see that these medications in these different classes can affect and directly impact the different variables that lead to that blood pressure elevation. So it's not just I take this pill and some magic happens. I'm actually targeting something directly that leads to that blood pressure elevation. And some of these actually work on multiple factors for your blood pressure. So let's take your RAS blockers as an example. So it affects your blood volume. It affects your venous tone. It affects your circulating regulators. So 3 different areas on both the cardiac output limb as well as the peripheral resistance limb are impacted by your RAS blockers. Look at your calcium channel blockers. Well, you've got venous tone impacts, you've got contractility impacts, some will affect your heart rate. So all of those factors impact your cardiac output side of the limb. And then you have calcium channel blockers that can directly impact the peripheral resistance. So you can see these drug classes can impact multiple areas, multiple factors that lead to your blood pressure control. So now that we know that there's multiple classes and there's so many different medications that fall under those classes, what are the medications that we should think of as our primary agents to treat blood pressure? It comes down to your thiazide diuretics, your ACE inhibitors, your ARBs for those who can't tolerate the ACEs, and then your dihydropyridine calcium channel blockers, so your heme medications. Those are your primary first-line agents. If your patient is on one of those medications, you are meeting the standards of care. So let's talk about briefly how each one of these agents work to control your blood pressure. So let's start with ACE inhibitors, probably one of the more common ones that you're going to see prescribed to your patients. So this inhibits the renin, angiotensin aldosterone system, particularly by working on this, this regulation pathway where it blocks the conversion of angiotensin 1 to angiotensin 2. Well, you can see the RAS system is a pretty complex system where you have really 4 organ systems working together to kind of regulate your blood pressure, right? So it's not just one thing that goes wrong that leads to blood pressure elevations. This is a tightly regulated system. So if we're going to try to block this, we got to make sure that we're blocking it at a level where you're actually going to have an actual impact. So this conversion of angiotensin 1 to angiotensin 2, it works by blocking the effects of angiotensin 2 that leads to the vasoconstriction of the blood vessels directly. But then it also blocks the reaction of the adrenal gland by producing aldosterone, which then affects the kidney function and that reabsorption of sodium and water, the sodium ATPase pumps. So there's a couple of ways that the ACE inhibitor works to lower your overall blood pressure. But one thing that actually is unique to ACE inhibitors that you don't see with its cousin, the ARBs, is there's another pathway that actually has a local vasodilatory effect that gets blocked, that leads to the vasodilation locally. And that is the ACE inhibitor medication blocks the conversion of bradykinin into the inactive peptides. So it's blocking that, that destruction of the bradykinin, which then means you have higher levels of circulating bradykinin, which then triggers an additional release of nitric oxide, which has a local vasodilatory effect. Okay, so by giving an ACE inhibitor, I have this additional mechanism to lower blood pressure. Now, when we talk about the side effects, unfortunately, elevated levels of bradykinin can cause a cough. So ACE inhibitors, we always talk about, one of the side effects is cough, and this is particularly why we see that. When we talk about the cousin ARBs, the mechanism of where this works is actually one step lower from the ACE inhibitor, and now you see that you're blocking angiotensin 2's action on the blood vessels, so you don't get that vasoconstriction anymore. But then you also block the impacts of angiotensin 2 on the adrenal gland, so you're not getting that secretion of aldosterone that triggers that reabsorption of water and sodium in your kidney. So it works just one step down, has the same impacts on your blood pressure control, but it doesn't impact the levels of bradykinin. So patients who are put on an ARB do not typically deal with cough as a side effect. Now, one other additional highlight of ACEs and ARBs that we need to talk about is these are absolutely contraindicated for anybody who is pregnant or is desiring to become pregnant. So think about prescribing these medications to women who would like to get pregnant in the near future. If they are pregnant and they come in for their initial pregnancy test, they immediately need to get pulled off of this because you can see it can lead to fetal harm. So let's make sure we're giving every opportunity for that baby to grow and develop normally. And it could be something as simple as changing their medications. Now, if they need blood pressure medications and they are pregnant or desire to become pregnant, there are agents that they can be prescribed that have been shown to be safe for pregnancy. And these are going to be like your methyldopa, your labetalol, and even your nifedipine for Hydralazine can also be safe for pregnancy, but a lot of times we use that in more of like the treatment of like preeclampsia because it tends to not last as long, and there may be some additional side effects that go along with using hydralazine. But methyl-dopa, labetalol, and nifedipine are completely safe for our patients who are pregnant and have blood pressure issues. And then this is just a list of the side effects like we talked about. ACE inhibitors, kind of the one that is unique to ACE inhibitors is the cough. You don't get that with the ARBs, but all the other risk factor, or sorry, all the other side effects of ACEs you will see with ARBs. Okay. So really, the primary reason that you may put somebody on an ARB is that they have the cough side effect with an ACE inhibitor. Let's go ahead and take 10 minutes. We'll come back and finish up. Angiotensin-aldosterone system. Let's now talk about a different classification of drugs and talking about the diuretics, which when you talk about diuretics, you've got to make sure that you add some additional information to let us know what kind of diuretic you actually are talking about, because not all diuretics are the same. We don't use diuretics as a blanket term to say blood pressure, because when we talk about loop diuretics, we're going to be using those for like heart failure stuff. So block 3 of our class, we're going to be using loop diuretics. So don't use loop diuretics to control blood pressure. We'll talk about potassium-sparing diuretics, and we'll talk about why these are not necessarily a first-line agent to treat blood pressure, but they do have a role in blood pressure management, and then also in heart failure treatments. We'll talk about using those to help with heart failure, but it's not a primary first-line agent to use. So thiazide diuretics are our primary agents that we use when we talk about using a diuretic to control blood pressure. Don't memorize this. I expect that you learn this in freshman semester. Just know that the diuretics, they work on different parts of the nephron, particularly like the collecting tubes and stuff like that. Based on where they work, kind of determines what impact we're going to have. So loop diuretics work on this ascending loop of the loop of Henle. And you can see that they cause a reabsorption of, they cause you to lose sodium, potassium, and chloride, which means you have water kind of falling behind it. So that's that diuretic part to it. It's not until we get to the distal convoluted tubule that you see the thiazide diuretics, so your hypertensive diuretics work. And you can see when you take a thiazide diuretic, it causes sodium and chloride to get dumped, which then pulls water along with that. And then when we talk about potassium sparing, now we're looking at the sodium potassium ATPase pumps here, where now when you take a potassium sparing, it causes potassium and hydrogen to get reabsorbed, and then you dump sodium and water out, which lowers your blood pressure and gives you that diuretic effect. So when we talk about thiazide diuretics, this is also a very common first-line agent to use it because studies have shown that it can reduce cardiovascular morbidity and mortality from hypertension. So in literature, we actually see a morbidity and mortality benefit from this medication when it comes to hypertension. What else do we see in literature? For somebody who is on it, we expect a 15 to 20 millimeter drop in their systolic and at least an 8 to 15 millimeter drop in their diastolic by being on this medication. And these are pretty well tolerated. You just have to know that, hey, if I am having kidney function issues, I have chronic kidney disease, I'm dialysis dependent or whatever, thiazides are not going to work necessarily. So you are going to have to change their medication rate up if there is a decline in their kidney function while they're on this medication. So, so be careful of thiazides in somebody with chronic kidney disease. There are some downsides to giving a thiazide diuretic, and mostly kind of think of this as a problem with your electrolytes. I'm causing my electrolytes to shift abnormally or in a non-controlled fashion because I'm trying to lose all that additional water, right? So I've got to be careful and I've got to monitor my electrolytes appropriately because you don't want somebody to develop hypokalemia. You don't want them to develop hyponatremia. If they are somebody who has, if you have somebody who has a history of gout, so they have those elevated uric acid levels, thiazide diuretics are not recommended for these patients because it can precipitate gout flares. So now you have somebody who you know has gout, you put them on a medication, and now they're having more frequent gout flares, and because of the uric acid clearance issues associated with thiazide diuretics. So you may need to change your regimen, or you may need to not do your normal agent on that individual patient. So make sure you take your history and look at their past medical history and tailor the medication regimen appropriate to that patient. Potassium sparing, so spironolactone is kind of the primary one that we talk about with potassium sparing, but there are others in that class. They are weak diuretics, but they also, according to literature, don't really have as much of an impact on lowering the blood pressure. So this is why we don't use these as monotherapy or as a first-line agent for blood pressure management. However, there is some blood pressure lowering. So if you were to use spironolactone for one of the off-label uses, you've got to be careful of what it's going to do to the blood pressure. Let's say you have somebody who's already on 2 agents to lower their blood pressure, and then they come and see you for, let's say, PCOS, and they want to be put on spironolactone. What's going to happen to their blood pressure? Just because you're using that spironolactone for the hirsutism part of PCOS doesn't mean it's not going to cause an impact on your blood pressure. The body doesn't work like that. So be careful of adding these agents for one condition and how it's going to impact the blood pressure. So spironolactone, you're going to see a lot of this recommended for heart failure exacerbations, but somebody who doesn't have heart failure, we primarily use it for like the anti-adrenergic effects. So the hirsutism and PCOS for women. We see it also with difficult to control acne in women. We try to steer away from prescribing this to men because it can block that testosterone. It can actually lead to the development of gynecomastia. So be careful of using spironolactone in your male population. So that's your potassium sparing diuretics, and actually that's your diuretics in general, okay? Let's move on, let's talk about our calcium channel blockers. So when we talk about calcium channel blockers, make sure you know which flavor of calcium channel blockers you're talking about. Because your non-dihydropyridines, we are not going to use these in blood pressure management necessarily. Because these have more of an impact on the myocardium, particularly affecting like the contractility and the rate of your heart rate. So the non-dihydropyridines, such as your diltiazem and verapamil, aren't blood pressure agents. Really, you're going to want your dihydropyridines, or the ones that end in the pene, as your blood pressure agent. So your amlodipine, your nicardipine, your felodipine. Those are your blood pressure versions of calcium channel blockers, because these have less of a cardiac effect and have a much more profound local vasodilatory effect on your blood vessels. And the way they work is they block that inward movement of calcium ions into the smooth muscles of the arteries. Remember when we talked about calcium being important for the function of the myocardium, the contraction of the myocardium. Kind of think of this as the same as the smooth muscles lining the blood vessels. That calcium is necessary for the constriction of it. So if I block that calcium inflow, that means then I have less vasoconstriction, which means I'm going to have more of a vasodilation effect to it. So that's how calcium channel blockers like the amlodipine work to control blood pressure. These are great antihypertensives even in your elderly patients. So these are good to use. The biggest things you need to watch out for is, okay, maybe I'm giving them too high of a dose or they're reacting excessively to it, so maybe their blood pressure is going to drop too much. But kind of the major one that I see causing folks to get their medication switched is actually the ankle edema or the edema side effect for it. To the point where that swelling may make you think that this patient has heart failure. So it's not just they're a little swollen, they're coming back and their ankles are like 2-3 sizes larger than normal. So that's the most common side effect that triggers somebody to get their medications changed when it comes to calcium channel blockers. Now this isn't a first-line agent, but your alpha-1 adrenergic blocking agents, we primarily use these for other things. They used to be first-line agents, but because of the side effect profile to them, we've stopped recommending these as first lines. But now we usually think of using these in like our elderly male patients who have BPH or the benign prostate hyperplasia to help them be able to urinate better, right? We'll put them on it. But similar to when we talk about spironolactone, this can cause a drop in your blood pressure. So if you have an elderly patient who has hypertension, and then you start them on one of these medications for BPH, be careful of what it's going to do to their blood pressure, because it could drop it too far, and now they're having hypotensive episodes because of that, and now they're falling and hitting their heads. And especially when we're talking about elderly patients, imagine what's going to happen if they fall and hit their head. So be careful using these agents for BPH when you have a patient with hypertension or on other antihypertensives. Alpha-2 agonists, these work great at lowering blood pressure, and we typically use these in like the hypertensive crises kind of stuff, or if you have a pregnant patient who has hypertension. But we don't have these as first line because of the side effects, particularly like the anticholinergic side effects that are associated with these alpha-2 agonists. But they do have a good result or clinical efficacy with controlling blood pressure. It's just we use these in a very select population and not as a first line agent. Beta blockers, so we think of these as more impacting the heart rate, right? But because it does affect your cardiac output limb of the blood pressure equation, it does have blood pressure implications. But outside of labetalol, you usually don't think of these as being used for blood pressure management, because the blood pressure drop that does happen with this is not as profound as we would see with our other first-line agents. But it is, especially labetalol, is safe to use during pregnancy. So there is an indication for blood pressure management in this. What's our side effect profile for beta blockers? Well, I'm going to lower my heart rate. If I lower it too much, and now my cardiac output isn't adequate to maintain perfusion, then I could be passing out or almost passing out. It can affect your mood, your sleep, may have some sexual side effects. So there's lots of things that could happen with this, which is also part of the reason that this is not a first-line agent, because it does have these side effects associated with it. Then we have our hydralazine, which is a direct-acting vasodilator. And this is not a first-line agent, but it is used in our hypertensive emergency or hypertensive crises type patients, which includes preeclampsia, so hypertensive crisis in pregnancy. It does have blood pressure effects, but not a first-line agent, but there are indications to using hydralazine. And that just works by the vasodilatory effect, so it just dilates those arteries to lower that blood pressure. So now that we know what to use to treat, what do we do as far as our goals for things? Fortunately, the AHA-ACC guidelines actually have a path to help us determine how to treat these patients. So remember, according to the ACC-AHA guidelines, stage 1 hypertension starts when you have a BP that's greater than 130, or in the 130s over 80s. And they want you, if you have this patient, assess their clinical ASCVD, and if they have greater than 10%, then you're going to do a non-pharmacologic therapy and a blood pressure lowering medication. If they are less than 10%, then they usually recommend a non-pharmacologic therapy. So lifestyle changes is what it recommends. If you have stage 2 hypertension, according to the ACC-AHA guidelines, which qualifies as a blood pressure greater than 140/90, then they recommend both lifestyle and a blood pressure lowering medication, and then seeing if we get to our goals. So, and this just kind of summarizes that. When you have particular populations that you have to be careful of as far as what you prescribe, and this is why I say don't just say my normal or my usual is I start off with this. Make sure you're tailoring your treatment regimen based on your patient. So for our African American patients, ACEs tend not to work as well in that population in lowering blood pressure. So this is where you would probably want to do more of the calcium channel blockers or the thiazide diuretics for this population. We talked about our pregnant patients not being on ACEs or ARBs. For our diabetics, because of the renal protective advantages of ACEs and ARBs, then consider having your patient on an ACE or an ARB in order to manage their blood pressure, because you're getting not only the blood pressure control, but you're also getting that renal protection that unfortunately our diabetics often suffer from. Now, a lot of times, especially if you have a patient who has stage 2 hypertension, a lot of times one antihypertensive is not going to be enough to get them to goal. So how do we do multiple agents? How do we begin that? So if you have somebody who has like a blood pressure of 150/100, this person's probably going to need 2 agents, but how do we do that? According to the literature, there's actually 3 strategies that you could do this. The first strategy that the literature talks about is you can start one drug, titrate to the maximum, and then add a second drug. So kind of doing that stepwise fashion. Another strategy is start one drug and then add a second drug before achieving the maximum dose. So you know they're going to need 2 agents. Let's start them on this one dose or one medication first, and then quickly add another without titrating to the max. And then the third approach is just immediately begin the two drugs at the same time. So the literature supports either one of those three ways to get them on two agents. I can tell you from personal experience, I'm hesitant to do the third option. And the reason for that is if I start them on two medications at the same time, one, they start having side effects that they don't like. Which one's doing it? How am I going to take off an agent to see if that, whatever side effect is coming from the calcium channel blocker that I put them on or from the ACE that I put them on? So that's one reason I'm hesitant to do it. The other reason I'm hesitant to start them on two agents is potentially that patient has been having a blood pressure of 140, 150s systolic for a period of time. What's the chances that I caught them with that elevated blood pressure within the last month? It's probably something that's been going on for at least a year. Their body has adjusted to having a higher blood pressure. I start them on two agents and I immediately drop their pressures down to 120s. What's that going to do? That's almost the equivalent of giving somebody who has a normal blood pressure of 120, I give them a medication and now they're at 90 systolic, right? So now, even though the number on the machine does not read hypotension, that person, their body is reading that as hypotension, and now they're having pre-syncopal episodes because you've lowered their blood pressure too quickly. So that's my concern with starting two agents at once. So I kind of will do a mixture of the first two options. So I may say, well, let's see, we're borderline, maybe we only need one agent, just maximally dosed. Let's do that one first. And then, okay, we max dosed that agent, that ACE inhibitor. Now let's add that calcium channel blocker. Or if I know that they're going to need two agents, then I may just say, okay, let's start on ACE, like lisinopril 20 milligrams. See how you do with that first, and then we'll add that amlodipine 5 milligrams and kind of see where you go from there. So we're going to titrate those dosages independently of each other. So be careful about putting them on two agents at once. That's my personal experience. But the literature says you could do that if that's how you want to do your practice. Fortunately, for your patients who do need multiple agents, there are a lot of different varieties out there of two agents in one pill. So this helps with compliance when they're only having to take one pill instead of taking two pills, right? And there's a lot of different variations out there. So there's an ACE inhibitor and a thiazide combo pill. There is a ARB thiazide combo pill. There's a beta blocker and a thiazide combo pill. There's even a diuretic. So this would be like a thiazide and a spironolactone combo pill. So there's different versions out there so that you can still have them on two agents but take only one medication, which just helps with compliance if they're only having to remember to take one medication during the day as opposed to having to take one at breakfast and one at noon and one at dinner time and then another one at bedtime. So help your patients with their compliance by minimizing the complexity of their dosing schedules. There are some other medical conditions where you may have to kind of change their medication regimen up a little bit to help with that condition as well. So like heart failure, yes, you can give them really anything that we talked about as far as first-line agents. If we're doing post-myocardial infarction, so they had a heart attack, then we're thinking like beta blockers, ACE inhibitors. We'll talk about why that's a good thing to have them on those agents after they've had a heart attack. And then we talked about how our patients with chronic kidney disease or diabetics, because they're at risk of developing this, why ACEs and ARBs are kind of our recommended primary agents to treat that. And you can see that if you wanted to see it actually in a guideline, this is that recommendation. So you have a hypertensive patient with chronic kidney disease that is showing that they're having chronic kidney disease because they're spilling protein into their urine, then an ACE inhibitor is recommended. And then if they are ACE inhibitor intolerant, meaning like cough, then put them on the ARB. So ACE and ARBs in your chronic kidney disease patients. Now, when it comes to managing that difficult to control patient, there's a number of things that you can do to look at it. So we talked about at the very beginning where a lot of your patients, because they don't necessarily have a symptom related to their blood pressure being elevated, but they are going to have side effects related to the blood pressure medication you give them, those patients may not be compliant with your regimen or your recommendations. So how do you manage these patients? Well, you don't want to be like Tom Cruise and A Few Good Men and sit there and demand the truth. You want to work with them. You want to kind of load your boat on people to help them take care of themselves. So this could be including getting family involved, get their spouse involved, get their kids involved to help them and convey the importance of doing that. So having that conversation of, yes, I know you're not feeling anything now, but 20 years from now, you're going to have a heart attack, and now you're not going to be able to go upstairs, you're not going to be able to play with your kids, you're not going to be able to play with your grandkids because of the heart attack, that kind of thing. Find out why they're not compliant with their medications. Maybe there are some cultural or some religious things going on that's interfering with why they don't want to be on that medication, okay? Kind of saw that with like our COVID vaccine, all the people requesting religious accommodations. Some were BS, some were real. So there is that, but there may be a cultural or religious reason why they don't want to be on the medication you're putting them on, okay? So try to work with your patients. If you come out like Tom Cruise, you immediately ruin that provider-patient relationship, and they are not going to listen to you, and in fact, probably will never come back to see you. Unfortunately, I saw that in a patient when I was a medical student who was diabetic, who stopped taking her medications because she didn't want to take them anymore. Her provider kind of confronted her in an aggressive kind of manner, and she did not come to get seen for 3 years. She stopped taking all her diabetic medications for 3 years. She comes in because she can't see. And it's because of the diabetic retinopathy. Her A1C was 17 when she came in. And she permanently, from there on out, had basically a page with like 2 letters on an 8.5 by 11 with a magnifying lens for her to actually be able to read what's going on. That's how bad her vision was, because she lost confidence and faith in her medical team to take care of her diabetes, so she stopped all treatments and left. And yes, you can document in your note, the patient didn't listen to you. However, you could have saved that patient from their own demise by at least approaching them, talking to them, addressing their concerns and stuff like that. So, for patients who, they are taking their medications and they still don't have a control of their blood pressure, that's when you start to get specialists involved. Maybe there's other things going on. Maybe it's a secondary hypertensive patient and you're not managing the pathology that's actually causing their poor controlled blood pressure. Maybe you get some of these other specialists like the kidney doctors, the nephrologists, the cardiologists, the internal medicine providers on board to address maybe some other things, and maybe they can come up with some off-label uses of things and come up with a regimen that actually works to control their blood pressure. So load your boat with folks, with experts to help you manage your patient in these difficult to manage patients. So what do we need to do from a prognosis standpoint, from a monitoring standpoint, in addition to just checking their blood pressure at least once a year? Well, we've got to check their electrolytes, because all of the agents that we are going to put them on will affect their electrolytes somehow. And each one is going to cause a different derangement in their electrolytes. So we got to make sure that we are monitoring those derangements appropriately and intervening, because some of these can be arrhythmic. So we may cause an arrhythmia to develop that could kill them because we don't monitor these electrolytes appropriately. So make sure you monitor the electrolytes appropriately. Unfortunately, just by ordering your basic metabolic panel or your Chem 7, depending on your institution and how they call it, most of these will be on that panel. The only one that will not show up on these panels is your magnesium. But guess what? We already said that loop diuretics are not something that we typically give as an antihypertensive. So for your primary first-line agents for antihypertension, we tend to give the Chem 7 or the BMP will give you those electrolytes that you need to monitor appropriately. So let's go back and finish up our case. So we had that patient who was admitted to the ICU who was started on IV antihypertensives. With IV antihypertensives, they were able to bring her blood pressure down to systolics in the 160s. She was discharged to her primary care provider to continue working her up and adjusting her medications to an oral regimen that may control her blood pressure. She continued with 3 antihypertensive agents and still taking the high potassium. But she saw her urologist because she had a history of kidney stones that had required a lithotripsy. And her urologist said, I remember in medical school talking about a disease similar to this. Let me consult my textbooks. Well, it turns out she had a secondary form of hypertension called Conn syndrome, which leads to an elevated secretion of aldosterone inappropriately that caused this, and ultimately ended up having surgery to remove the tumor on her adrenal gland, and her blood pressure became easier to control. The problem was, because this had been going on 20 years, the damage had already been done. The chronic damage had already been done, so she ended up going from 3 agents down to 2 agents to control her blood pressure. But if it had been caught earlier, she may have been down from 3 agents to no agents. So early diagnosis is important. And this is actually the story of my mother before I went to medical school, where she had these severe blood pressure elevations despite being on multiple agents, and nobody could figure out what it was. They just kept throwing pills at the problem without actually thinking about her medical condition, and that there might be something else going on. So it's just a highlight of how managing blood pressure can be complicated. Questions about what we talked about? So tomorrow we'll talk about second